Thank you, everybody. Thanks for having me here. I've had a wonderful couple of days here in Cincinnati and have enjoyed the discussions. So the title of my talk is Predictors of Remission in Autoimmune Liver Disease, Data Summary of the Retrospective A-Link. And for the purpose of this talk, we'll be focusing on autoimmune hepatitis. I have no relevant financial disclosures. So for autoimmune hepatitis, the incidence of the disease is 0.1 to 0.23 per 100,000 children. 12% of all referrals to tertiary care liver clinic, which was in this case King's College, were due to autoimmune hepatitis. 22% of all autoimmune hepatitis had an acute presentation. In the first generation of the PALD study group, about 8% of all patients aged 3 to 18 were due to autoimmune hepatitis, and autoimmune hepatitis in the latest SRTI report in pediatric patients accounted for about 4.9% of all pediatric liver transplants. So one of the first studies or retrospective studies in children with autoimmune hepatitis was published by the King's College group by Dr. Georgina Melivargani, and she included 52 children in her initial 1997 paper, 32 of whom had type 1 autoimmune hepatitis and 20 had type 2 autoimmune hepatitis. 12% of these kids presented with fulminant hepatic failure, 10% went on to have a liver transplant, and then there were 22%, or 1/5, who had associated autoimmune disease. And here on the right side, you can see AST levels on the y-axis and years on the x-axis, and kids with autoimmune hepatitis type 2 and type 1, and their median levels were plotted here. And about at 1 year, the median levels in 14 autoimmune hepatitis type 2 and 28 autoimmune hepatitis type 1 were somewhere close to 50 or 40, and about 84.6% of their cohort had biochemical remission. Now, one of the largest multi-centered retrospective studies which I am aware of for children with autoimmune hepatitis came from Brazil, and actually Dr. Bazera was one of the co-authors on this paper. And so there were 819 children who were included. 60 of them had autoimmune sclerosing cholangitis, and 759 had autoimmune hepatitis. About 4% underwent a liver transplant, and 5% underwent unfortunately had a demise. And 76.3% had biochemical remission. Now, as opposed to the previous King's College experience, they found that type 1 autoimmune hepatitis was associated with worse survival with native liver, along with autoimmune sclerosing cholangitis and lack of biochemical remission. And better survival was, the factors which predicted better survival were higher AST, ALT at diagnosis, and higher albumin levels at diagnosis. And this Kaplan-Meier curve on the right shows just the data on these 759 children with autoimmune hepatitis, and one can clearly see worse survival, significantly worse survival shown on here with the red line in type 1 autoimmune hepatitis as opposed to type 2 autoimmune hepatitis. So differing populations may show differing predictors of outcomes. And so what about the North American experience thus far? And these are all retrospective studies. So there was a multi-center retrospective study from Canada, which included 159 patients. The racial composition was not clear in that paper. Again, one can see similar patterns in the incidence of liver transplantation and death in these patients. 5.6% underwent liver transplantation and 2.5% had died, and 90% had a complete biochemical response. Now, these terminologies, biochemical remission and complete response, I've seen used interchangeably in manuscripts. So I've stuck to what the manuscript defined. So 90% had complete response. Now, the Atlanta experience was a single-center retrospective study, and it spanned a number of years, starting from the late 1990s, going up to 2010 or 2012, and they had 109 patients in their single retrospective study, all with autoimmune hepatitis. The significant aspect of this publication was, as opposed to every other publication, was 42.2% of children in their cohort were African American, and they found that, as opposed to some of the data that I've shown and the other cohorts mentioned here, they had a higher rate of liver transplant, 23.8%, and a higher rate of mortality at 3.6%, and a lower rate of complete biochemical response, 55%. I'll be elaborating this in my next slide as well. Now, the Denver study was from Children's Hospital, Colorado, was a single-center retrospective study. 66 kids, 86% of them were Caucasian, and again, 6% liver transplant and 3% mortality. 79% complete biochemical response was what they had discussed. Now, this is the Atlanta study again, and two graphs showing the challenges that they had in treatment of African American children. The one on your left is showing this Kaplan-Meier curve showing inferior survival in African American children as compared to non-African American children with native liver over time. And this graph showed that the proportion of children at 1 year who were on high dose, like more than 5 milligrams of prednisone, proportion of African American children who were on greater than 5 milligrams of prednisone was significantly higher than the non-African American. Now, again, signifying not only that it's difficult to get biochemical remission, but it is also, they are also exposed to higher doses of steroids and hence side effects. Now, a recent publication by the Autoimmune Hepatitis group defined a few parameters which maybe we can use going ahead about what they mean by these different terms which are used. So complete biochemical response was normalizations of serum transaminases and IgG below the upper limit of normal, and they said should be achieved no later than 6 months. Insufficient response was just lack of biochemical response. Non-response is less than 50% decrease in serum transaminases within 4 weeks of initiation of treatment. Histological remission was hepatitis activity index less than 4 out of 18 points, and intolerance to treatment is any evidence possibly related to treatment as assessed by the treating physician. Now, evaluation, and since we are going to study predictors of biochemical remission, I thought I would spend some time on this. Now, evolution of biochemical remission. In 2002, the guidelines said that the aim in autoimmune hepatitis was to reduce AST and ALT to about 1.5 to 2 times the upper limit of normal. And if one does a follow-up liver biopsy, it is enough that the inflammation be confined to the portal tracts, no interface activity, and slow progression to cirrhosis. And the goal was to minimize immunosuppression and to maintain remission and minimize serious side effects. Now, the guidelines in 2019, and which was also consistent in the recent guideline in the guidelines in 2010, and which is also consistent in the guidelines in 2019, define biochemical remission as normalization of ALT. and serum biochemistries and normalization of IgG, with the caveat that IgG levels can be elevated in individuals who have cirrhosis at presentation. And histological remission was defined as elimination of portal lymphocytic inflammation, as opposed to some leeway by the previous guidelines, and an elimination of interface activity. Now, this is important because here are two recent publications, one recent publication here in 2022, which shows what happens if we have different targets. Now, more than 2.5 upper limit, if at 1 year after initiation of treatment, the levels of serum transaminases were more than 2.5 times the upper limit of normal, their survival with native liver was significantly lower than those who had biochemical remission, which shown by this top line. But if we target the old criteria, the 2002 criteria for biochemical remission, one can see that the individual survival with native liver was also significantly lower than the current definition of upper limit of normal. Now, this is also another study from an Italian multicenter, adult study from an Italian multicenter, who analyzed their patients and classified them as having remission or not based on either the 2002 or the 2010 guidelines. And those, if one followed the 2002 guidelines, there was more progression during remission as opposed to the 2010 guidelines. And so that brings us to, so if there was a clinical decline, as in development of ascites, a radiological change, it was a retrospective study. So if there was clinical radiological evidence, or even those who underwent a liver biopsy, if there was progression in their disease severity. So it wasn't a constant, they defined it one way and went forward. They went back and looked at patients who had a follow-up, and they knew for sure had for this study, I think they used 20 these study and 30.
That is quite impressive.
Yes.
That is even a difference to our study. Yes. So I think I think I can only encourage to pay attention to it. Where you put the cutoff makes a huge difference for everything. Sorry, one question. Did they also see that those with the new guidelines that you would end up on higher immunosuppression for a longer period of time?
I don't think they did that. It was, Alex, it was a very short letter to the editor kind of a thing to the guidelines which were published. See, these came up in 2010. And if you see here's like a short, it was just a one and a half page, which this diagram kind of a thing. So there was not a detail. It wasn't an original article here for this. This was an original article. This was the current, in clinical gastroenterology, hepatology. So
very nice. Thank you.
So with this background, what we started to do in our retrospective analysis, we have included patients since 2010 up to 2021, and we have started to collect some data. So after the institution of these new guidelines, where most clinicians would be targeting the at least the upper limits of normal, and not 1.5 to 2 times the upper limit of normal. So in that era, post 2010, we have started collecting data on patients with autoimmune liver disease. Now, so this was the prioritization. We have about 14 patients at our center with PSC and 12 with ASC, and at Cincinnati, they have 28 patients with with PSC and 9 with ASC. And for autoimmune hepatitis, at our center, we have about 35, and at Cincinnati, they have about 67. And just for the purpose of this study or this presentation, in the last couple of weeks or so, we prioritized the data entry for autoimmune hepatitis. And so going forward on these slides, everything, I know it might be a little confusing and I'm showing a lot of data. Everything in blue will be from our center in WashU or St. Louis. Everything in the red is from Cincinnati. And so the median age at diagnosis at our center was 13, the mean age similar, 12.24. The distribution of patients, so I told you, I showed you on the last slide, 23 from our center, 27 from Cincinnati have been entered. There are more entries to be done, even for autoimmune hepatitis, but this data is based on 23 and 27, about 50 patients. So at our center, the age group 1 to 7 had 8. At Cincinnati, they had 3. 8 to 11, the prepubescent 2 at our center, and 9. 12 to 15, 10 at our center and 9 at Cincinnati, and 16 to 19, 3 and 6 respectively. Again, you see a female predominance in both cohorts here, as expected. 17 out of the 23 at our center were girls, and 15 out of 27 at Cincinnati were girls. Now, I feel this is an important slide with distribution, because this is where I feel that we can, collect more data and have more diversity. I showed you in one of the previous slides from the Atlanta experience, the impact of race on outcomes and on difficulty of treatment and achieving endpoints. At our center, out of the 23, 22 were white and 1 was African American. At Cincinnati, again, majority 21 white, 1 white, a mixed white plus African American, and 3 were African American, 1 was Asian. Again, at our center, 1 Hispanic patient when we look at ethnicity. Now, keep this in mind when we go through the subsequent slides. As well, in terms of diversity of population. Disease presentation, the most common symptoms, like we talked about yesterday, jaundice was the most common symptom, followed by abdominal pain, not too surprising to the group here. And that was consistent both at our center and at Cincinnati as well. Now, at our center, 1 child presented with acute liver failure and fulfilled the PALD-FSG criteria and underwent a liver transplant within a month. 2 presented with decompensated cirrhosis, and 1 of these 2 underwent a liver transplant within a month of diagnosis. And 2 additional patients, in addition to these 2 patients, 2 additional patients had portal hypertension defined by the children criteria at the time of presentation. Now, just going forward and going through the next slide, where we'll be looking at biochemical remission, the total number of patients where we at Children's analyzed biochemical remission was 21, because 2 patients, right, 1 with acute liver failure and 1 with decompensated underwent a transplant within a month. So we could not look at those endpoints in those patients. And in our group, 3 had concomitant lupus, 1 had Hashimoto's thyroiditis, and 1 has type 1 diabetes. In the patients I analyzed, there was no concomitant IBD, but there are more patients to be analyzed, and I think there will be some concomitant IBD, at least in our cohort. Labs at diagnosis, going through this really quickly. There were high AST, ALT at diagnosis. GGT was about 1 to 2 times upper limit of normal median at the time of diagnosis. IgG was high, protein was high. The albumin and INR, the median levels were within normal limits, and then the bilirubin, total bilirubin was high, and the platelets were not low at the time of diagnosis. 17 were ANA positive, 15 were smooth muscle positive, so type 1 autoimmune hepatitis. 4 were LKM positive, 1 who underwent transplant was, yes, Cynthia.
A question about the, you have one African-American patient at each center. Was there a difference between the response in race in your centers versus Atlanta? And because I don't see, you had one also who who needed a transplant. Did you distinguish between the race issue? And then also, was NAFTALI also considered as a comorbidity?
Repeat the second question again.
Was NAFTA a non-alcoholic fatty liver disease
as a comorbidity? So to answer your first question, I don't know the details about the Cincinnati African American or the mixed race, mixed African American white population. Maybe Shelby or Alex could tell us about that. Like you, right? The one African American young girl in our cohort was the one who presented with acute liver failure at diagnosis and underwent transplantation. So that was one, the answer to your first question. Now, NAFLD is an important comorbidity to look at. I think I apologize for the wrong for this heading. I meant to say other autoimmune comorbid conditions here. I'll have a slide at the end with overweight and obesity, and then of course NAFLD is an important consideration. Yes, Amy.
Yeah, and I can talk about the Cincinnati data. So I think that this is. So I think this is kind of taking with kind of that this is kind of this is a random sample of patients who are currently, so it's not the full cohort. So this is about 1/3 of the patients who are screened into this study. So we have screened into this study. And so for the Cincinnati data, it's not complete. So it's, the first 30 patients. And so I think that I would, the way that as we were talking through this data, I think it's good to kind of see trends, but I think especially when we only have a number of patients, with different races and different ethnicities, it's really hard to draw conclusions this early. What I will say is that as we were kind of looking at the different sites and centers, we have the benefit of having a bunch of centers from different places with different patient characteristics and patient populations. And that was intentional, recognizing that depending, certain centers don't see as much diversity as others. And so, that's what we're really excited about as we onboard more centers and more sites to do this, to be able to get a full complement of data to be able to address those types of questions in specific patient populations. I would love to. Yes. So this is Shelby Mecklenburg. She is she's a student who is going to be pursuing a career in medicine. So for all the site PIs, take note. But she actually collected the data for the first 30 patients, had incredible insights as we were designing the database. And so she knows our data very well. So feel free to jump in and answer questions too, Shelby.
All right. Moving on, treatment, the treatment of autoimmune hepatitis. And here you'll see a little bit of diversity in practice between two centers. And so at our center, 18 patients were started on prednisone. And at Cincinnati, 10% was initially started on prednisone. At our center, 9 out of the 18, about 50% had a flare. At Cincinnati, 4 out of 10 who were started on prednisone as the initial treatment had a flare, so 40 to 50% flare rate. We did not have any patients who were initially started on budesonide only in this time epoch, between 20, again, this is a partial analysis. So there might be some, but we did not in this initial analysis. There were 9 at Cincinnati who were started on budesonide as the initial treatment, and only 3 of them had a flare. And at our center, 3 patients were started on prednisone and then converted to budesonide, and none of them had a flare. And at Cincinnati, 8 patients were started on this combination of pred and budesonide, and 5 had a flare. Now, here's the other difference that you will see between the 2 centers, and whether it has to do with the diversity of patient population, which has been treated at 2 different centers. I don't know, but that could be my guess. We had of the 21 patients who we analyzed, 9 were on mercaptopurine, and 12 were in 12 azathioprine was used, and only in 1 of these was converted to a CNI due to issues with not achieving the therapeutic targets. While if you look at Cincinnati, there were 2 on mercaptopurine, 21 on azathioprine, 5 on Cellcept, 4 who had either CNI or mTOR inhibitors, 5 on anticholestatic, 5 who had antibiotics, 6 with TNF biologics. Maybe was this for autoimmune hepatitis? I'm not sure, because again, in our cohort there was nobody who thus far had IBD, but again, anti-TNF biologics and 1 on other biologics.
Yeah,
Yeah, so again, I think when I thought about this, I don't know whether that has something to do with this as well, and then what Atlanta found as well, because I'm sure they're using the same protocol, but you see a stark difference in the biochemical remission rates and liver transplant rates there. So again, that was my thought, because I went through the charts for the purpose of this, and it was like clockwork at our center: steroids, azathioprine, biochemical remission in most patients, with some flares here and there, but no difficulty per se in terms of treatment. So maybe the size of the center, the diversity of population, your catchment area, I think that those might be some of the
population also in this initial cohort also includes patients with autoimmune hepatitis, IBD, actually. And so thank you, Shelby. That particular patient population with autoimmune hepatitis, IBD, with or without PSC, I think has presented some findings. So in terms of the anti-TNF biologics and the other biologics, so there are some patients with ASC, because as we were doing our first studies, we were trying to include patients with that to be able to kind of see how the REDCap database would capture that and how we could make the SOP work for that. And so, yes, we do have a number of patients with autoimmune hepatitis who are in remission on anti-TNFs, a full spectrum of them. We also have patients who were entered into remission on anti-TNFs, and because of overlapping IBD are on other biologics. And so that data is because of I think the IBD in our population that is part of this cohort.
Thank you. Thanks, Amy. So this is the other thing which might shed light on the diversity of medications used versus not at 2 centers. Here, again in blue, 6 months biochemical remission incidence was 71.4% at our center, as opposed to 56% at Cincinnati. And at 1 year, biochemical remission was 85.7% at our center, as opposed to 74% at Cincinnati. And looking at 6 months steroid-free biochemical remission, 9.5% at our center, as opposed to 4% at Cincinnati. And at 1 year, steroid-free biochemical remission rates were 23.2% these were quite similar, 23.8% at St. Louis Children's Hospital and 22% at Cincinnati. Again, I feel that this underlines, one is practice differences, and two is the volume and the diversity differences at the two centers.
I think it worthwhile pausing a little bit on that slide. First of all, can you say how did you define remission in this is obviously the retrospective Ailing study for which you and Amy have developed an SOP, and we have all the same definitions across all 11 centers of how we define the population and how do we define remission. What remission criteria did you use?
For the purpose of this analysis at St. Louis Children's Hospital, less than upper limit of normal was what.
So which is actually for most of the age groups in the 40s, right? It's not even 19 and 30, which is in adults. And if I remember correctly, having seen a lot of our data, many patients actually hug the 40. If we used the adult criteria, which would be justifiable because the Schwimmer data would suggest that it should also be 25 in children, we would probably even have a lower rate of remission. So I do think it is very important if we look forward to justify intensified studies. This is a good example. I think it's very different from what everyone believes is going on in autoimmune hepatitis. Oh, that's an easy to treat disease. It isn't, despite all these medication and despite having almost everyone still on steroids, which would be completely opposite what everyone is expecting based on the ASID. We don't really see remission that much. And that is with a higher level. I mean, we are giving some leeway. If we were stringent, I bet we would probably be down to 50% remission.
Same.
So I would note that was actually one of the things for the autoimmune hepatitis definition of remission. That was one of the first priorities for the autoimmune hepatitis working group of Ailing, is recognizing as we were building these standard operating procedures that there's a lot of back and forth in the literature at different centers, how we wanted. And so there was a lively discussion in the autoimmune hepatitis working group. I think a little bit of dissatisfaction with the current guidelines of liver enzyme normalization. What are normal numbers supposed to be in kids? And so we went kind of around and around, not around and around, but we had a nice discussion about it, but ultimately decided that we were going to use these very stringent definitions and be thoughtful about how we define relapse. And so I think that was, helpful where, our multidisciplinary, groups were able to help define outcomes for the research aspects of Ailing. And so yeah, so we're using a pretty strict definition. For the retrospective study, I would say, just as a note, the IgG was not a component of it because a lot of centers weren't obtaining IgG. So that will be something we're implementing going forward. But for that, because I think that we're defining outcomes based on remission, that, it's important, Alex, as you brought up, to say, how are we defining that?
And so just one more thing. So did you also use upper limit of normal for the? Yeah, that's most of the studies which have presented in the background used upper limit of normal. Though I agree with the weakness there.
And actually it was a big part of how we built the REDCap database. And so because every center, every lab has a different normative value. And so there's a little bit of the onus on the centers because we ask at all of them, hey, what is the upper limit of normal? Recognizing that it's different based on age, based on sex, based on, the lab of where it was drawn and the interpretation. We wanted to make sure that we had really precise data for ALT and AST if we were going to use it as one of our defining outcome measures.
But I would not call that a weakness at all. I mean, I think this is very important to recognize. This is the first opportunity actually to see what we should define as the treatment goal. If we see this with upper limit of normal, which is in the 40s, how would be our outcomes if we did it with 25 being the upper limit of normal? being the treatment goal. And can we, in our retrospective study, can we find a Kaplan-Meier curve similar to the ones you showed earlier on in adults, which would tell us, is there a difference in outcome between patients who achieved 40 at 1 year and those who achieved 25 at 1 year? And should we actually, while Amy calls that stringent, I would say it's not stringent. It's actually permissive. The stringent would be 25. And, you know, that obviously it comes with a cost. If you end up pushing the bar that high, then everyone will end up on Prograf immune biologics. So this is a very fine line, which you and Shelby and Amy are exploring here. And I can't wait for 2023, the 2.0 presentation.
Yeah, those are, so the other thing, which again, this may or may not hold true when we finish off our complete analysis, but one of the trends which I observed, or which we observed about age at diagnosis and biochemical remission. Now, it's a busy slide. I'll just highlight the rates of biochemical remission. At our center, 1 to 7, 85%, 8 to 11, 0%, 12 to 15, 70%, and 16 to 90, 100%. At Cincinnati, 1 to 7, 100%, 8 to 11, 44%, 12 to 15, 44%, and 16 to 19, 50%. And this is at 6 months. Let me also read the values at 1 year and then make one point from this slide. So at our center, 1 to 7 at 1 year, biochemical remission, 85.7, 8 to 11, 0%. 12 to 15, 80%, and 16 to 19, 100%. And then at Cincinnati, 100% in 1 to 7, 33.3% in 8 to 11, 77.8% in 12 to 15, and 66.7% in 16 to 19. So one can see a trend of this prepubescent children not achieving biochemical remission at 6 months and 1 year. And this was statistically significant for me when I ran a chi-square analysis of that age group versus not. I've not seen literature to that extent, so I don't know. It's something to pay attention to, but I don't know whether that would hold true when we do the whole analysis. But it was interesting, I thought. What about flares? The rate of flares at our center was 43%. The rate of flares at Cincinnati was 44%. At our center, the median number of relapses or flares in patients who relapsed, in the 9 patients who relapsed, they had one additional, one flare. So that was the median number of flare. And then median time from diagnosis to the first relapse or flare in these 9 patients was 36 months. And the median time from stopping steroids to the first relapse in 7 patients, in 7 out of these 9, where one stopped steroids after the physician thought that biochemical remission was achieved, and then there was a flare, was about 24 months. So similar analysis will be required with more patients.
That must worry us, because we would think that if you are that far out, it's already safe to withdraw immunosuppression. And you see that most of them were probably on immunosuppression, and they are that far out, right?
Yeah, that was the experience. It was almost 2 years after withdrawal of steroids. So again, I think so this was coming to one of Cynthia's points. What about the side effects of steroids? How many had side effects of steroids without, these conditions were not present at the time of diagnosis, but developed after diagnosis? At our center, out of the 21 patients who had long-term follow-up, one had low bone mineral density, 3 were overweight, 1 was obese at Cincinnati. 1 was had hypertension, 1 developed low bone mineral density. But as you can see, one of the commonest things that we are seeing here is overweight and new onset overweight and obesity, likely due to steroid use. So interim trends, I shouldn't say conclusions, because I think we can't draw conclusions in this short cohort and future directions. So at 1 year post-diagnosis, the incidence of biochemical remission as defined by upper limit of normal was 79.1% in our combined cohorts, which is quite similar to what has been reported in previous North American cohorts, except for that Atlanta experience. And steroid-free biochemical remission was low, like Alex pointed out, 22.9%. The incidence of biochemical remission was lowest in the pubescent age group, which I showed you the trend, which was about 27%. Incidence of relapse was about 43%. A third of children had side effects which could have been due to the use of steroids. And in future direction, the couple of weaknesses of the current analysis. One is, I don't think we have the numbers, so more sites putting in data and increasing the number will help, and more sites with more diversity, I think, of population and of children will also help come to conclusion and analysis. That's the one thing which I think we can remediate. The one thing which we may not be able to remediate with even with more numbers and diversity is the differences in practices between centers and thresholds for using other agents. But we can always analyze that as separately and see and mention that as a weakness. Thank you for your attention.
Real quick before we get into questions, we're just going to do this one. If you have any more, write it down. We're running a little late. Give it to us at lunch and we'll make sure it gets answered.
I'm just curious, has there been any data between the steroid use and the mental health of your patients? Because I know when my son has been on steroids, I don't see that as being anything that's being documented here, but it's been a major issue in my son's life, and I'm sure in other patients as well, where that's a big one. It goes right up there with the rest of them.
I completely agree with that. The issue, at least at our center, I can speak, we haven't collected data, or at least in the previous decade, data on mental health and variables relevant to that. And so maybe it will be difficult with if other centers are similar, it will be difficult with the retrospective study, but that's the plugin for the next talk, which, which is the prospective database analysis, where I think it's really important to collect that data along with, the steroid dose, the changes in mental health. I couldn't agree more with you.